Hello, everyone. Welcome to this webinar, which is discussing virtual wards, which are going to be our magic bullet to ease NHS pressures, especially this winter. I've got esteemed colleagues on the call who will be introducing themselves in a moment. But let's just put this into context. We've got 7.1 million patient episodes. We've got about 5.5 million people waiting for treatment. What we know that we can't do this year is to stop elective activity. And that brings into play a very tricky balance of UEC pressures versus elective care. The pressure on beds is there. We talk about winter pressures, but actually those pressures are year long. It just feels like there's an added impetus as we go into November, really. It feels like it started already. So virtual wards are important if we can take a day off the care of every single patient who is an inpatient, or look at cohorts of patients where we can make a difference, both medical and surgical. It really will support the pressures that are happening on the beds that are on 100 and plus occupancy at the moment. And I think the fantastic presentations we have today, I think, are threefold. One is the initiatives and the range of initiatives. The second is that these are lived experiences and people have actually done and have actually implemented these examples. But the last, I think, is even more important. There is measurable change and impact because of what has happened. So if I may, Stephanie, may I ask you to introduce yourself, then Michael, then Jill, and then we're going to pass over to Stephanie for the first presentation.
Thank you very much, Stella. Great introduction. So I'm Stephanie Somerville. I'm Programme Director for the National Virtual Ward team and also Director of Community Transformation.
Hi everyone, I'm Mike Waters. I'm the operational lead for the virtual ward at the Norfolk and Norwich Hospital.
Hi everyone, I'm Jill Ireland. I'm the Chief Executive and Clinical Director for HomeLink Healthcare, and we work in partnership with the NHS providing virtual ward services.
So Stephanie, I'm going to pass over to you for your first presentation.
Lovely, thank you. I'm really excited to be here today, particularly to hear from Jill and Mike about the work that's actually happening on the ground. So what I'm here to do is to sort of tell you a little bit about the national programme and how that fits with building capacity, but also talk about some of the things we need to get right to implement virtual wards at scale. But before I sort of crack on, I just wanted to say a couple of things and to echo what Stella said earlier. So the virtual ward program is really ambitious, and what we're seeking to do is fundamentally change the way acute care is delivered. So hospitals are no longer the de facto place to treat our sort of cohort of patients who might benefit. And we want to create up to 20,000 virtual ward beds by March 2024. So it's a really significant program, and those beds need to be supported by tech. They need to fully integrate with existing services so that our patients have a more seamless journey between acute hospital level care and the virtual ward and indeed community health services. But this can't be done overnight. So although many systems are building virtual ward capacity over the winter, this is a 2-year transformational program because we need to put in the right the building and testing and iterating of virtual ward models where they aren't existent at the moment takes time and needs the right level of clinical support and buy-in. But as Stella said, the prize is absolutely huge, particularly for, of course, for our patients. And, we want to get into a position where, frail elderly patients who are experiencing an acute episode and a UTI or delirium no longer need to end up in A&E for hours or with a long stay of hospital, which we know can have adverse consequences for their mental and physical health. And that's just one example of the patients we anticipate will benefit from rolling out virtual wards at scale. So can I have the next slide, please? So I like to start with the definition. Just really important to understand what a virtual ward is and what it isn't. So virtual wards support patients who would otherwise be in hospital to receive hospital level care at home. And that might be through a referral from 999 or GP to avoid a hospital admission, or it might be a step down early transfer from hospital when a patient has had an operation and needs and can be at home with the right support around them. Common to this definition is that virtual wards are for a patients for a short length of time, up to 14 days, and have that consultant level oversight. Next slide, please. And of course, virtual wards sit in the ecosystem of virtual care, which might include sort of digital long-term condition management at home. But but what we're talking about here is really acute level care at home or in someone's place of home. And there are different types of virtual wards, as you will know, and they sort of segregate into kind of two different types of models. But there's obviously a dimension across those models, and those are those which are mostly remote, with a high degree of tech enablement, where early deterioration triggers clinical input. And we typically see this kind of tech-focused model for respiratory pathways. The second involves a much more blended model of digital platform support, but also face-to-face care, where you might see acute level interventions such as IV therapies happening in the home, sometimes on a daily basis. And this model tends to support patients with more complex conditions, such as patients living with frailty. The reason we're supporting systems to develop the model that is right for them, but as a minimum, we've asked every ICS, and that went out in the list at this time. Actually, it was in January last year as part of the operating framework guidance. We asked all ICSs to, as a minimum, develop pathways for ARI and frailty over the 2-year life of the program. But many systems, of course, expanding into other areas. Next slide, please. Virtual wards is actually supported by a growing evidence base, and there's good evidence. I hear often that there's no evidence for certain types of virtual wards, but that's just not the case. If you look at the evidence, there's good evidence that patients on virtual wards have comparable, if not better, outcomes and experiences than those treated in hospital, including quality of life outcomes. And because there are, although we're for the first time really implementing virtual ward models at scale, many virtual wards have been around for a while, particularly those hospital at home type models. And we also know, and what's really exciting is that patients just love them. And this is sort of borne out in some of the evidence that shows that patients really appreciate the ability to recover at home, but also to remain part of their family support network. And we're also seeing staff benefiting from more flexible working models, particularly where staff rotate through a virtual ward kind of model, but they may also have time, in a normal ward at a hospital. So that's great to see as well. I just wanted to play next a quick video which sort of illustrates those points in a much more erudite way. Can we play, please, Adam? I hope it's coming.
I just thought we would try it and it was a good idea because it was better because I was
So a virtual ward is a means to be able to provide care for patients in their own home that they would otherwise get in a hospital setting.
They wear a device and they wear that every day. It'll be their heart rate, their oxygen levels, and the skin temperature and the respiration, and that will download via the dashboard every 15 minutes, and we monitor the readings from the device. So it gives them that flexibility as well, that they can still go about their daily activities, and that we can fit in with their family life as well.
They're able to take control, take back control of their rehabilitation.
Staff have been fairly positive in their experience of virtual ward and virtual care delivery. It gives you the ability to be able to monitor a large cohort of patients and to be able to use your workforce resources quite effectively.
It's just the right thing to do. Using specialist teams in a different way has enabled them to deliver more care to patients.
Lovely. Thanks, Adam. Let's go to the next slide. So it's just a really nice synopsis of how virtual wards are working and some of the benefits. Just come to my next slide. So I guess why now? As Stella said, we know emergency admissions have been rising significantly over the last decade. We know over that same period, hospital beds have reduced and we're running at very high occupancy levels. So, hospital capacity is extremely tight. We can't carry on doing the same thing in the same way. And we have the tech and the skills to deliver care outside a hospital building, and it follows that we should be able to do that and extend our capacity to deliver those interventions at home. And virtual wards, when implemented with clear clinical governance, are a safe and efficient alternative to hospital, and we've seen that through the evidence that's developing. Next slide, please. And so there were. So this is really setting out why there's particular pressure right now. So in the recent letter that went out on to the NHS over winter, there's a specific focus on managing demand and capacity, and it included actually a commitment to work with local areas to develop more bed capacity, including virtual wards. And in addition to the our 20,000 ambition, so we're working with those systems to deliver 2,500 more virtual ward beds by the end of December. And that's really building on existing capacity and extending that capacity rather than starting virtual wards from scratch, although some systems are actually being super ambitious about what they're doing. Next slide, please. So where are we now in the programme? So we've had over 10,000 people supported by virtual wards over the last month. There are now 200 services reporting across the country, and and systems report through our sort of national SITREP on virtual wards. And those services are providing over 6,800 virtual ward beds. Actually, I think, since I saw the data this morning, we're at nearly 7,000 beds. And we are importantly increasing the occupancy within those beds, which is going to be really important to sort of ease winter pressures. Next slide, please. And this is really about, so I said at the beginning of my presentation, I mentioned we really need to get a few things right to support scale of virtual wards. And one of those is really using virtual wards as an opportunity to further integrate across health and social care. We know that the virtual wards can't be delivered as a standalone service. They need to be fully integrated with established teams, such as urgent care response teams, primary care, community nursing teams, rehab and enablement teams, and care homes, of course, and care home teams. And they need to build on existing services out there, such as out of hours services that are provided by community night nursing teams, and in some instances GP practices. And we really want to see the development of partnerships with the voluntary and community and social enterprise sector to really support the caring of people at home, because we know that the support for carers is going to be absolutely critical to make a success of this. Next slide, please. And then the second thing that we need to get right is the tech. And it feels a bit weird to say that virtual wards should be tech enabled, because, obviously they should be supported by a digital platform. However, some of our hospital at home models, which have been going for a while, don't have tech fully integrated yet. And when I talk about tech, I want to talk about it in the round. So at a core, there is a remote monitoring service, which allows patient condition to be escalated when there is deterioration, and allows the clinical team to talk to the patient and monitor with them their vital signs. Point of care testing is also fundamental as well, allowing clinicians to do diagnostics on the ground, including imaging practices and blood tests. And then thirdly, just have to get interoperability right to enable, we're going to have we have multiple teams in the community across hospitals and community services, and they need to be able to see what's happening to their patients. And that is easier said than done, but I know that systems are really working hard to make that a reality. And the final slide, please. Thank you. So I will leave you there. I think I'm just under my 15 minutes. These are the key sort of critical success factors we're seeing when different providers are talking to us about how they're implementing their virtual wards. Clinical leadership, I haven't talked about today, is absolutely fundamental. We need to see that integration. We need the tech to be right. And just coming back to my original point, this is an incremental approach. We need to build and test and iterate as well. Thank you very much. We've got a clinical summit. I just plugged my clinical summit on Thursday, which is fantastic. If you're interested, we can put the link to that clinical summit, which is a big 3 hours on virtual wards on Thursday, to get into some of the implementation in a bit more detail. So we'll pop that in the chat, but please do join. It'd be great to see some of you there. Thank you very much, Stella.
Stephanie, thank you very, very much for that. And the clinical leadership and the passion to try something different is where we're going to go first. Of course, the business as usual comes in as we get the trust and confidence of everyone as we go through. So, Michael, we're looking to you in terms of clinical leadership, engagement, initiatives, and then questions for everyone at the end. So, Michael, may we invite you to present?
Hi, yes, I'm Mike Waters. I'm the operational lead at the Norfolk and Norwich virtual ward here. So I thought I'd do a quick sort of précis of how we started, where we are now, and what are our plans going forward. So if we can have the first slide, please. So as all trusts were, on the 13th of January, we were asked by NHS England to set up a virtual ward, and this was to support the COVID crisis and getting patients home sooner or stopping patients from coming in the first place. It was at this stage that we sort of took a much bigger look at it and thought, actually, why are we keeping this to COVID only? And we started implementing a virtual ward that would encompass all specialities, initially starting with COVID, but with plans to take that forward in the future to support recovery as well. So we initially started, and we linked up with Current Health, which I can see from some of the previous slides, a lot of other trusts are using as well, to get the technology on board. And by mid-February, we'd started admitting our first patients. Again, these were mainly COVID patients that were just requiring monitoring at home. We said we wanted to start up an acute virtual ward specifically, and to follow the NHS England guideline to the letter, so that all of our patients would otherwise be in an acute hospital bed. We made it clear we did not want to be a discharge safety net or anything like that. We wanted to make sure that the patients that we had on the ward were specifically acute patients that would otherwise be in hospital. So we initially were funded to set up 20 beds, and we commissioned HomeLink to deliver the care in the patient's home. So that allowed us to do any IVs in the home that we were needed, any wound care, vac dressings, that sort of thing. So we brought HomeLink on board to help us deliver that care in the home. And we, as I say, we commissioned Current Health, and they were the providers for the technology that we use to this day. We wanted to make sure that we had a 24-hour service. As I say, our patients are acute patients. We didn't want to get to the point where at 8 o'clock at night you wouldn't shut down an acute ward. So we wanted to mirror totally an acute hospital ward. If we can have the second slide, please. So where we got to now, we're available to all specialities. Like I say, initially we started off with COVID. We now have well over 15 pathways that can lead into the virtual ward, but I sometimes think we get a bit hung up on pathways, and I think the most important pathway is our bespoke pathway, where we can fit around the patient. If we can do something in the patient's home and they don't need to be physically be in an acute hospital bed, then we will take that patient onto the virtual ward. As I say, we offer a 24-hour, 7 days a week service, just for that specific reason. 40% of our readmissions come in at night. So our concern would be if we weren't running a 24-hour service, what would happen to them patients overnight that we're escalating back into hospital. So we made it quite clear we wanted a 24-hour, 7 day a week service. Initially, that was very easy to staff because we were using COVID shielding nurses and doctors. So the staffing was there, they were at home, they were not allowed into the physical hospital. So we had a workforce there ready and waiting. Obviously, as the shielding has stopped, that has become more of a challenge because we don't want to take nurses away from acute areas. We know how short-staffed everyone is into this area. So what we've tried to come up with different ways. So we use nurses that are on long-term sick that can't physically manage a 12.5-hour shift on a ward. We use recently retired nurses who've got a wealth of experience but don't quite feel they can manage a physical 12.5-hour shift. But we don't want to lose that experience that they've got. So we've managed to keep the staffing up, and we've got our core team of staff that were here from the start as well. We've established a clinical team, so we mirror a normal ward. So we've got a pharmacist, we've got junior doctor, and we've got a consultant that runs specifically for our virtual ward. And that allows us to have a daily ward round, 12 o'clock each day. So every patient is spoken about, discussed, new plans made. Daily visits are slightly different. So we do a daily phone call face-to-face via the Current Health app with the patient. That allows us to go through the medications to confirm they're on the right medications, that they're taking the right medications, and everything else. I can just see you can't actually see me by the looks of it. So I'm trying to sort my camera out. Might just probably a benefit that you can't see me, but there you go. So we make a phone call at least once a day to our patients on the ward to check that they're okay. And that's absolutely lovely. That's from our nursing staff perspective. I always say it's like going back to old-fashioned nursing, because you have a one-to-one with a patient. You've got 10 minutes to talk to them. You've got no other distractions. You haven't got someone asking for a cup of tea or asking to go for a wee or asking other questions. So you get to know your patients really, really well. You get to know their family, what they're doing that day. You also then get their trust. So we've had so many cases where we've found out other details, important details, just through talking to them. They might say, "Oh, I didn't want to say when I was on the ward because it's not particularly confidential. I haven't had my bowels open for 6 days." And you get to learn so much more because you build up that trust and you are one-to-one, just you, just them. Our nurses absolutely love it because, as I say, I'm an old nurse, but it's like going back to old-fashioned nursing rather than quick visits to each. Our technology allows us to monitor our patients, as I say, 24 hours a day, 7 days a week. The observations come through every 15 minutes. So we're really, really good at seeing a deteriorating patient. We can see them, get something implemented and stop that deterioration. And if they continue deteriorating, on our trust, we keep them as inpatients so they can immediately come back into the hospital without going via A&E. And that way, so that's the way we work. And I'm sure there'll be questions about this afterwards, so I'll go into that in more detail during the questioning. As I say, we've got 15 plus pathways, vax therapies, IV therapies, surgical pathways, cover all specialities. But as I say, our most important one is our bespoke pathway. We always say, if you refer 100 patients and we take 10, we'd much rather that. We'll do what we can to take patients away from the acute hospital bed. If we can have the next slide, please. So what we've created currently is that patient gets home quicker. So they'll come in, initially they're coming in. If we can turn them around quick and get them out sooner, then that's what we'll do. We all know that patients recover more quickly in their own home. So certainly for our COVID patients, we saw that the recovery was much quicker. Whereas if they're in hospital, laying in a hospital bed, they might move and sit next to their bed. That's as far as they're getting. If they're at home, they're getting up, making themselves a cup of tea, getting their lungs working, clearing them lungs. It's so important to get them home and getting them back to their own environment. Again, looking at dementia patients, keeping them in their own environment. The monitoring we have is bespoke, so we can set alarm limits to suit the patient. So they'll only alarm if they go without them patients. A COPD patient is going to have a different requirement of monitoring to a patient that's on a surgical pathway. So everything is bespoke to the patient. We find our patients really enjoy the security of being monitored. On the night shift, it's really difficult as a nurse to say, right, shall I ring this patient? Their monitoring sort of slightly out. Have they just fallen asleep? Are they? We ring them at 2 o'clock in the morning, and actually what we find is they're not annoyed by it at all. They're actually really grateful because they know that we're keeping an eye on them. Makes them feel so much safer, allows them to sleep better, which again aids their recovery. less clinical risk of hospital-acquired infection. You know, the recent pandemic and flu epidemic that's going to be coming our way shortly, I'm sure. Patients in their own home, there's lots less risk. I always think it's a really old-fashioned idea that we bring vulnerable people into a large building full of infection. That just seems a really old-fashioned way of dealing with it for me. So, you know, this is health in your own home has got to be the way forward. From the clinician's point of view, it's new and flexible ways of working. So what we were finding was, as the wards were getting fuller and fuller and fuller, so you have a gastro ward that's full, the next patients would then have to move onto a different ward somewhere else, or onto an escalation ward. So the consultants and the medical teams are having to go around various different wards to see their patients. Now we've only got the one gastro ward and then their virtual ward, so they can do their normal gastro ward all round and come on and see their patients, log on and see their patients virtually, rather than having to travel all around the hospital and that sort of thing. Much better flow. I think at last count, I think on one of our, it's coming up in a little while, is that we've saved, I think by the end of the week, we'd have saved something like 13,000 bed days since we started in February 21. And we know for a fact that they are proper bed days as well. So we only take on patients that would otherwise be in a hospital bed. So we know that they are proper saved bed days. Can I have the next slide, please? So I think the next slide was going to be, where are we now? So as I say, we've got a 40 bed capacity. We're available to all specialities. In fact, I've already done this slide, haven't I? So we've gone slightly over where we're going to go for the future. So what we're looking at, as I think Stephanie was talking about, we need to do some admission avoidance. So I know in this hospital alone, we've got nearly 300 patients with no criteria to reside. We know that's not going to change anytime soon. It's going to be a big ship that we've got to turn around. So actually, it's how do we stop these patients coming into the hospital environment. So we've taken on a project manager who's working alongside our care homes and alongside our voluntary services and our community services. We're trying to find ways of working with the care homes, with the community teams, in order to keep the patients at home. So we've got an ongoing project that's going on till March of next year to allow this to happen. It's having really good results. So initially it's working on earlier discharge back to a care home. So for instance, if the patient was fit to go back to the care home on the Friday, but they can't take the patient till the Monday because the GP is not going to be available over the weekend, they'll go home to that care home under virtual ward care until we can hand over to the GP on Monday. So just getting them out that slight bit earlier. And now and that's worked really well. We're now starting to work on how do we stop them coming in the first place. So it'd be working alongside the ambulance service. If they can take our kit out to a patient, so that if they see a patient, think actually they can be all right on the virtual ward, just start some IVs, probably save them coming in. We can set all that up and get that going. And that's where we want to go towards for the future. I think that's all I've got to say currently. So as I say, I'm sure there'll be some questions towards the end. But for now, I'll hand. Oh, actually, we've got a quick video to show, if that's okay. Thank you. Hopefully, we won't have the echo.
It's the middle of October at 3 in the morning when Carol Whitlock anxiously waved at her husband as he was conveyed to hospital with COVID.
I remember one consultant getting down by the side of the bed and just simply saying, you've got to fight this.
3 weeks later, instead of staying in a ward, he's continuing treatment at home. An armband monitors vital signs, sending information to nurses. David gets twice daily calls.
I feel quite bright this morning.
Oh, all of your observations are looking really good my end. Have you been checking them yourself with your pulse oximeter?
The last time, about an hour and a half ago, it was about 94.
David is double vaccinated but has non-Hodgkin's lymphoma, so his immune system is low.
Thanks for calling.
You're very welcome.
At home in the virtual ward, he was hooked up to oxygen for 5 days.
When he first phoned me to say would I be able to pick him up when everything was arranged, I was a bit surprised, I guess, and Am I going to cope? Is it going to be all right having him at home? Will he get the support that he needs? Will it all be down to me? But actually, as it progressed, all my fears were allayed.
It was another step that you sort of thought, oh, you know, moving out of the security of the hospital. But the more I thought about it, the more I liked the idea. You know, the hospital is brilliant, but it's not like being home, is it?
At the Norfolk and Norwich, equipment's being delivered for more patients to move onto so-called virtual wards. 40 have moved home in total.
It means those patients are not occupying inpatient beds with us. And of course, for most of us, we don't want to be in a hospital bed. We'd rather be at home. So if we're not in need of active nursing and medical care, this is fantastic.
And it also means that you need fewer nurses per patient.
Absolutely. For those patients, the resource intensiveness of the staff we need to run our acute wards is much lower.
David's still breathless, but at home he can challenge himself every day, while a bed is saved for someone with more complex medical needs.
And Nikki's
So I think that just sort of sums up our service really. Getting the patients home, they are really, really grateful for that. And what I wanted to just point out as well, which made me think about it afterwards, was that our tech is really, really simple to use and can be used by anyone. It's done on a mobile signal. I'm anticipating questions for later, so apologies. So we don't digitally exclude anyone, and we have got volunteers that can go out and set up kit if there's a person that is not particularly tech savvy. But anyway, thank you very much. That's you've heard enough from me, I'm sure.
Michael, thank you very much. It's generated lots of questions in the chat as well. So if I may, I'm going to hand over to Jill. Jill, it'd be great to hear your thoughts.
Okay, thanks very much. That's great. So if I could just have the first slide. Okay, that's absolutely fantastic. So just like to share with you probably over the next sort of 10, 12 minutes or so, a bit about HomeLink, a little bit about how we work in partnership with the NHS to set up and deliver virtual wards. Some key considerations for setting up a virtual ward really, based on our own experience of working with multiple partners across the NHS. And then just a little bit more around sort of reporting and evidencing the positive impact that virtual wards can have. So if we can go to the next slide. So just a little bit about HomeLink really. So HomeLink Healthcare, we've been up and running and supporting virtual ward services in the NHS and with the NHS since about 2019. And we're absolutely delighted to work with Norfolk and Norwich, setting up our first virtual ward, which then, as you've heard from Mike, has evolved and developed into bigger things. But our team are still very much on site at the Norfolk and Norwich Hospital and continuing to support clinical delivery for patients at home on the Norfolk and Norwich virtual ward. We believe that absolutely there is, I should say, pressure on the inpatient bed base. We've heard from the presenters already today that this is an ongoing and probably long-lasting situation. But HomeLink believes that there are beds available and they just happen to be in patients' own homes. So we're all about working with the NHS to support transfer of patients from hospital to home. We deliver a whole range of hospital at home type services. As I say, virtual wards one of the pathways that we've delivered. So over the last couple of years, we have saved the NHS around about the equivalent of 77,000 bed days. We've safely delivered over 61,000 home visits and cared for over 3,000 patients. So we're very experienced in this area, and we're always looking to work with new NHS partners to scale existing virtual wards or to start and deliver new ones. If I could have the next slide, please. So just to start thinking a little bit about how we work in partnership with our NHS colleagues, and how virtual wards can be successfully developed and scaled. So you'll see in front of you on this slide, in our opinion, there are probably 5 sort of key elements to building virtual wards and scaling them. And in the next couple of slides, I'm just going to focus on some of the key elements. When HomeLink begins to work in partnership with the NHS, what we tend to do is to start off from a point of co-design. So if we can move to the next slide, that would be great. So in terms of co-design, what do we mean by that? So we mean that before we actually start treating patients at home, it's really important to engage all key stakeholders who will be involved in either commissioning the virtual ward or delivering the virtual ward or experiencing the virtual ward. And we spend a fairly significant amount of time ensuring that everybody that's going to be involved, as I say, in the virtual ward is part of that co-design process. Critical to that is really thinking about what are the needs of the virtual ward? So what are the demands? So as Mike was saying, you know, the virtual ward may start off delivering, say, 1 or 2 pathways, for example, respiratory or frailty. And then those pathways then can be scaled out to deliver different clinical pathways and support patients with a whole range of different needs. So, for example, the work that we originally initiated with the Norfolk and Norwich team, we started that sort of co-design sort of principle, really, based on an understanding that the needs of the hospital and the needs of the patients at that time, back in 2019, so way before COVID, was about patients in hospital requiring IV therapy, point of care testing, which could be delivered quite safely, efficiently and effectively at home. So the starting point for the virtual ward, that the service that has become the virtual ward for Norfolk and Norwich, was all about identifying that need for patients at that time, which was mainly around the need to have their ongoing treatment, predominantly IV therapy, and the associated clinical interventions that they were currently having in hospital, and transferring those patients to home. And that became the nucleus of our first virtual ward. Usually the co-design sort of phase, if you like, of virtual ward development and design takes several weeks. I absolutely hear that the need to set the virtual wards up is there, and there is increasing demand and pressure on that inpatient bed base, but I really can't overestimate the importance of spending time at the beginning of your virtual ward journey, sort of co-designing the service, engaging your clinicians, your commissioners, as I say, your patients, the teams that will be delivering the service in that co-design phase, because that really sort of sets off the virtual ward journey in a very sort of positive and engaged way. The next slide, please. At the heart of the co-design process is really the importance and the significance of clinical leadership and governance. So it's during these discussions that we will agree our clinical pathways. So as I say, you know, if we're starting, let's say, with a respiratory pathway, because that's the demand and that's the need at that moment in time, then really think about your inclusion and exclusion criteria for that pathway. We absolutely are committed to caring for as many patients at home as possible, but there will be some parameters around that. So, you know, we want to make sure that the patients that are transferred from hospital to home, or those patients who are on a mission avoidance type virtual ward pathway, you know, the decision to care for those patients at home is underpinned by safety. And at the heart of that safety discussion has to be which cohorts of patients would be safe to be cared for at home, and those that would not. Part of the clinical leadership and governance framework is around risk assessment. So, we've heard from Mike and Stephanie the importance of, that assessment phase for patients. So in our virtual wards and those that we are currently running, we carry out a risk assessment with the patient whilst they are still an inpatient to make sure that we fully understand the home circumstances for that individual patient and that we identify any risks that may impact on that person's care delivery once the person is at home. We also think very carefully about key points of escalation. So as Mike was saying, using the virtual remote monitoring technology, we can set individual clinical parameters for each patient, depending on their clinical baseline and depending on their key points of escalation. So, for example, when do we need to contact the clinical team at the hospital and escalate patient's deteriorating condition? When should that become possible? And those are agreed for each patient before those individual patients are transferred out of the hospital to home. We like to talk about clinical leadership and governance as part of a governance matrix. And that's about, who is taking accountability, overall accountability for the virtual ward, for the patients. In the majority of our models, that overarching accountability is with the acute trust, because the patients remain under the governance structure of the acute trust. Responsibility, though, for care delivery sits with HomeLink, so there has to be complete and utter transparency around that governance and accountability responsibility matrix. For our services, we offer a fully integrated solution. So what do I mean by that? So for our virtual ward services, we have an on-site team. So HomeLink clinicians will be based on the acute hospital site in the main, working with the clinical teams within the hospital and outreaching to the community teams that we obviously work very closely with. Our community clinicians are based in the field, but are in daily contact with the hospital-based team, making sure that there is ongoing integration and communication between, that is happening in the home, and feeding that back into the MDTs that are based on site and into the hospital-based clinical teams. Part of the clinical leadership and governance piece, and obviously the agreements that need to be in place before a virtual ward is launched, is all about safe staffing. So we've heard from Mike around the benefits of virtual wards in terms of opportunities for new ways of working, rotational posts, etc. And I believe really enhancing the kind of opportunities for retention within the NHS, in a landscape where we know that there are many nurses who are, sadly leaving the NHS to seek other careers and other opportunities. We absolutely want to do as much as we can to retain that expert, clinical resource within the NHS and other health professionals too. Virtual wards offer a real opportunity, I think, to promote, different experiences for nurses and other clinicians, caring for patients, as I say, in their own homes. But underneath all of that has to be, the agreement at the outset about what are the safe staffing levels, what are the appropriate numbers for per nurse or per allied health professional to visit in the home. What is that safe staffing model? What does that look like? And that's really important that that's agreed and signed off between all parties before the virtual ward goes live. There's also the very, significant and important piece of this around delivering clinical visits in the community, in patients' own homes. And that's the governance around lone working for our individual clinicians. So here at HomeLink, we have a remote monitoring provision software solution for our individual clinicians. So we know when a clinician has reached a patient's own home. We know that when they've, entered the home, we know that they've safely left the home. And we've got that sort of, capability, if you like, to track and make sure that our lone workers are safe. But again, this is a very important part of that virtual ward setup and making sure that you've got the appropriate checks and balances in place around that. Clinical leadership and governance then for HomeLink, where we wrap up all our operational procedures, processes, and all of the elements that I've talked to in our operational model manual. And that manual is a blueprint for delivery of the virtual ward. So when we work with our partners, the operational manual, which can go into several tens of pages, has every agreed pathway that we've co-designed. It demonstrates or includes the inclusion and exclusion criteria for patients. It includes points of escalation. And as I say, the way that I would best describe it is as the kind of blueprint for service delivery within the virtual ward. And at the heart of it, obviously, is the need to have that integrated incident reporting. For us, we co-report all our incidents and events with our NHS partners, and those are hardwired into the governance structure of the acute trust or the commissioners that we're working with. The next slide, please. So, how do we know, that virtual wards are working and delivering in the way that we have sort of co-designed and co-produced them? Well, we've heard from Stephanie and Mike around some of the national sort of SITREP reporting requirements, and absolutely those need to be built into the design and delivery of your virtual ward. From a HomeLink perspective, we will work with our commissioners and partners to build in KPIs which can help us understand and build the evidence base for virtual ward delivery. So, for example, we may be looking at the number of patients we've cared for or that have been cared for on the virtual ward. Our KPIs and tend to be both a combination of qualitative and quantitative measures. We will be looking at the length of stay on the virtual ward. We're looking at bed days saved or bed days saved equivalent. And we'll be looking at value for money. So not only, is the virtual ward safe and effective, but it actually offers, value for money for the NHS, and especially important at scale as we move out. We make sure that we've got our workforce reporting KPIs in place so that we have evidence of providing the right care in the right place at the right time according to our contractual requirements and agreements. We also agree at the outset how frequently our KPIs and other reporting outcome measures will be reported. So this is particularly important, obviously, in the partnership work that we do in terms of the models that we deliver on behalf of our NHS commissioners. And we also report on a whole range of incidents, transfers back to hospital. So, we will know that because of the acuity of the patients that we care for on the virtual wards, that a cohort of those patients will be transferred back into hospital. That's not unusual at all and is to be expected. And we look at those transfers back in terms of some of the national benchmarks and indicators that we have. So we know that for a hospital virtual ward, a hospital transfer model, you're probably looking at around about 12% of all patients will need, because of changes in their clinical condition and clinical changes, natural changes in their clinical conditions, that they will require to be transferred back into hospital. So we collect that data and then we review with our NHS partners that transfer back episode. And do sort of case studies around that to make sure that we can learn any lessons if there are any to be considered. So the next two slides then will just take you. I'll just take you through some of those KPIs and outcome measures that we have in a little bit more detail. So if I can have the next slide, please. Actually, if we could go back a slide. Sorry. So just on this slide then, just to bring this one to life a little bit for you. This is just a screenshot of our reporting dashboard. We've got near real-time reporting capability, so we can share this kind of data with our NHS partners. And then if we could just move to the next slide. Okay, that's great. Thank you. And this is just a screenshot for you of some of the patient-reported outcome measures that we collect. So we collect, we have patient experience data and tools for collecting patient experience. And more recently, we've built into our virtual ward model a self-validated patient self-reporting outcome measure called the EQ5D5L tool. And that tells us really across 5 key indicators, the level of improvement that the patients experience on our virtual ward. So what that data tells us, sort of at a high level across all our virtual ward services, is that the patients cared for on the virtual ward are reporting around about a 23-24% overall improvement in their health status across those 5 domains. Okay, so if we can move to the next slide. Okay, that's great, thank you. So as Stephanie was saying, really, I think one of the most important things with the virtual ward is around, starting small, testing, learning and growing. So, my advice is that, thinking about setting up a virtual ward, build from that's working and scale up from that perspective. Don't try and sort of do too much too soon. I know I'm acutely aware of the pressures that are on the inpatient bed base, the growing waiting lists for patients, and the need for effective utilisation of inpatient beds and the development of virtual wards. But really, I would advocate that we sort of start small and scale up once we've got some confidence in the virtual ward model that we are trying to develop. Maybe launch with small cohorts of patients, make sure that your systems and processes and points of escalation are working well, make sure that you've agreed and co-designed and during the sort of build-up phase actually works once you move into that into service delivery, and continue to do that. I think that is absolutely critical to the ongoing success and future of virtual wards. So the next slide then, just in summary then, accountability and responsibility, absolutely yes. I think those are probably best agreed and presented in the accountability responsibility matrix that we spoke to earlier. Identify, what you need, what are the key pressure points, and co-design your virtual ward to meet those pressure points and needs for your organisation. And as Mike says, each organisation will probably have a slightly different set of needs, but really take the time to understand those and to build out the virtual ward that meets those requirements. Start small, test and learn. And the whole piece around engagement and feedback and reporting is really critical to making sure that all our stakeholders remain on board throughout the virtual ward journey. Feedback points and touching points are agreed at the outset, and keep up that communication, because that's really at the heart of safe, effective virtual ward delivery. And the last slide, please. So, I hope that you've enjoyed the slides we've shared with you during the session this afternoon, and we're always really keen to talk to talk to you about the virtual wards, about HomeLink, so really happy for you to reach out and contact us and talk to us directly. Thank you very much.
Thank you very much. If we can have the slides down, and if I may ask all presenters to put their cameras back on, That would be really helpful. Now we're coming to the end of the webinar. We've got 6 minutes to go. So there was a couple of comments that I just wanted to pick up from the chat. Stephanie, first of all, thank you for the link and the offer to pull people in as extras. That's people have already started adding their email addresses. Secondly, Raj, you've made a very good point, as has others. David's story was quite powerful. Whatever we do, it has to bring along an operational process, the clinical champions who are the professionals, but also the public. So 2 quick questions. One is, how are we sharing those important patient stories that inspire confidence, and how are we involving carers? Just to give people notice, we've got 5 minutes to go. Who would like to pick that up? Michael or Jill?
Okay, yeah, no, absolutely. Shall I start off? Absolutely fine. So in terms of patient and family engagement, as I say, absolutely critical to the ongoing success of our virtual ward models. And we have a patient and carer survey that we receive feedback in that kind of standardized way. We also, as Mike says, really, as our individual clinicians visit patients and families, we take feedback about their experience of care and how we can continuously improve that and respond to that. So it's very kind of real-time patient engagement and taking that feedback and building that back into our sort of service development and an ongoing review.
Yeah, I think, sorry, for North Canary, I was trying to sort my camera out. That's why for some reason it stopped working. But as I say, that's probably an advantage to your. From our perspective, we use the friends and family test, and that's shown as our BI report shows. We're at 98.2% patient satisfaction, very satisfied at the moment, which is brilliant. Any patient feedback we get, we share certainly throughout the trust, and we get lots and lots of patient feedback. Just this week, we've had someone who has made us a George Cross. He said, I can't present you with one, but I'm made you one anyway. And just this morning, we've got someone who's written us a poem called Earthly Angels about being woken up at 5 o'clock in the morning by our phone calls. And how can you complain when they're monitoring us about that? So it's really nice. So we get feedback from that point of view, but you're probably right. We should share it more widely to shout about how good the service is and how good virtual wards are going forward. So there probably should be a better way of doing it. Yeah, I can send you a picture of that. Yeah, I've got both pictures of that. It's not a problem. As far as carers are concerned, it's more empowering them because we're not there to take the place of the carers, and we do involve the carers certainly in a lot of setting up the kit. We speak to a lot of carers in the meantime to help with that. We speak to the carers on a daily basis if that's necessary. We involve them in any of our discussions. So yes, we do involve the carers as much as we can.
Michael, thank you very much. And as I say, the patient stories I think came through as the most powerful of all elements of this. Clinicians who are worried, anxious, tired, don't want to do something differently. The conversation, which is, I would rather be home than in a hospital, is really powerful. Stephanie, there is a question in the group with regard to what happens when BT go over to cloud. I'm not going to ask you to answer that, but I wonder whether you would pick that up separately with Mo Smith. I think that would be really helpful. But Stephanie, I am going to hand over to you to summarise and finish the webinar. Really 2 questions for you. One is, in terms of a central resource, is that something that the futures could hold, or is there a plan for that? And then really a summary of how and what you have heard today.
Thanks very much, Stella. So we do have a futures resource, and actually I think it's the most visited futures resource at the moment. We get a huge number of hits, so it is a goldmine in terms of sharing best practice around virtual wards. So I can also perhaps send that on after the webinar, otherwise I'll just have to dig around now. I just wanted to say I am always really inspired by hearing stories of people actually doing this and making it work. And how optimistic people are for the future, and that people are convinced that this is the future. So we don't really need to do any persuading when they see, when I think when clinicians are brought in and when you're really seeing patients benefit, it just does beg the question about why on earth would we do this in a different way. So it's really wonderful to hear that. So thanks very much for inviting me today. It was great to be here.
Thank you very much. And just as last comment, I wonder whether the next one of these we do actually should bring in patients who've experienced this, and the lived experience of patients needs to be the next GovWet webinar. So let's just hand it over to patients and ensure that they know we're there to support them, and hospital isn't always the right place for people to be. Thank you everyone for your time in presenting. Really, really clear. Stephanie, you've said there's £450 million to be rolled out. Everyone needs to be bought into this, managing it. It's going to make an immense difference to the NHS. So thank you all for your time.